Here that lectures. Good evening, all. We will discuss the remaining part, the part 2 of laparoscopic umbilical port entry. So basically, the effects of obesity on umbilical artery, umbilical entry. So we'll discuss the effect of entry, effect of obesity. What are the effect of obesity on umbilical entry? Umbilicals entry. Okay, so basically when obesity will happen, because of obesity, you can see this is your umbilicus, this is your umbilicus. As the obesity will increase, non-obese, this is your non-obese, the directions is like non-obese to overweight. Okay, so this is a non-obese, the umbilicus is at the center. In overweight, the umbilicus now just sliding down, this is your umbilicus. In obese patients, you can see the umbilicus is shifting downward because of dragging, sagging of the skin. Okay, so actually in a non-obese patients, the angle of insertions, the angle of entry is 45 degree, because you can see if you go directly 90 degree at the level of umbilicus through this, you can injure the vessel. So you have to go 45 degree angulations. This is the angle with the horizontal is 45 degree. Okay, so how you give? So the right handed needle thrust has to be given, and with your left hand you have to elevate the abdomen. Okay, so basically the non-obese patients, you have to give 45 degree angles to avoid great vessels. For overweight, it's slightly increase, and the angle of entry gradually increase from 45 degree to 90 degree in obese patients. So here you can see the angle is 45 degree. The chances of injury to the vascular injury is less in non-obese patients. So in non-obese patients, the entry point is very easy but dangerous, because the chances of injury to the artery is very more. But in obese patient, the safer, difficulty entry but safer, because it is 90 degree, it is always away from the aorta. Okay, so next is your Hassan open approach. In this Hassan open approach, the small incision at base of the umbilicus we have to give. Then dissection has to be done till facial plane. Then what will do? Fascia is held with Alice or Cocker's forceps. Tent has to be done. Tented sharply. Then you cut it sharply seizure. Then suture has to be placed at each angle of the fascia and anchor to the Hassan cannula. That will help in closure. Okay, you can see the incision is given. Then skin, after the skin incisions, the edges, the facial, the skin incision given till facial plane. This fascia has been tented. The with the retractor is given. The Alice forceps, you can give incision by seizure. Then you have to this edges has to be suture with the suture. Then you have to enter the Hassan cannula. What are the correct methods of use? One will check, confirm the correct placement. If you compare both the technique, there is no advantage in preventing visceral or vascular injury by open approach and but there will be, in open approach there will be less chance of failed entry. So open approach have less chances of failed entry. What are the methods that we will use to check, confirm the correct placement of the varus needle? First, your opening pressures, opening intra-abdominal pressures has to be always negative, minus negative pressure has to be there. And you have to check by hanging drop techniques. You have to put 2 to 3 drops of drops into the attaching syringe end of the varus needle. Then it will be sucking into the abdomen, sucking into the abdomen. Okay, then syringe barrel test can be done. Double click sound. Okay, we always know the clicks while inserting. Click failed due to loss of resistance. Okay, if you there will be two umbilicus. If you give at the level of umbilicus, insertion is at the level of umbilicus, there will be two clicks. Why? Because you know there will be an anterior layer of rectus sheath and peritoneal layer. So in that case there will be a two click only. But in case of if it is given above the umbilicus, if the supraumbilical port, there will be a three clicks. The difference is because you know the rectus sheath has two layer above the arcuate line. So there will be a anterior layer, there will be a posterior layer of rectus sheath, and third one is your normal peritoneal layer. So three clicks above the umbilicus, two clicks at the level or below the umbilicus. You can see the methods of checking. Methods used: check that needle is working, spring action has to be there. Before you going, you have to check the needle, the spring action of the needle. You floss with saline, and incision always start at umbilicus. Hold correctly by a pen grip manner. Left abdominal wall insert, lift the abdominal wall and insert. The methods of use I will discuss. The methods of use. First, before going to the use, you have to check the needles. Check the needle is working or not. What is that working options you are checking? Check the needles is working, that is the spring actions. First point. The second point is you have to floss with saline to see the patency of the channel. Third point, you have to check before going to give proper incisions. Incision at the level of umbilicus before entry into the abdominal wall. Then you have to hold correctly by a pen grip manner. Then fifth point is lift the abdominal wall with your left hand. Then we insert. So before going to insert, you have to check the needle whether it is working or not. The spring action has to be checked. Then you have to floss with saline. Then you incision given umbilicus, hold correctly by pen grip manner, lift the abdominal wall while inserting. Then insert. Already told all this method. Test aspirations, floss, saline drop test. Then the creating pneumoperitoneum. The most common gas used is carbon dioxide gas. The low flow circulations is 1 liters per minute. The flow rate is 1 liter per minute. Occasionally the high flow, that is 4 to 6 liter required. The intra-abdominal pressure should not be exceed the mean arterial pressure, that 20 to 25 mmHg. The maximum pressures the maintained to be done 10 to 20 mmHg. The gas flow has to be 200 to 400 ml per minute. So basically in supplementary setting there will be a set pressure. What is the set pressures? What do you call by a set pressure? Tell me. Set pressures means the maximum pressure the machine allows to build inside the abdominal cavity. Set pressure is the maximum pressure. Maximum pressure the machine allows to build up inside the abdominal cavity. This is the set pressure. Okay. So normal set pressure, this is the set pressure has to be 14 to 60 mmHg. Normal set pressure is 14 to 16 mmHg. The maximum is 18 to 20 mmHg at the time of entry. So the set pressure has to 14 to 60 mmHg. Maximum at the time of entry is 18 to 20. It should not be exceed more than 20 to 25. Because if you give more pressures, that will cause IVC compressions. More pressures will cause IVC compressions. And the less pressures, if you give less pressure, that will cause less distension of the abdominal cavity. Then what is set flow? Set pressure is the maximum pressure of the machines that will allow to to build inside the abdominal cavity. The maximum set pressure has to be 18 to 28. The average is 14 to 60. If you give more pressure, that will be compression, IV compression. If you less pressure, that will less distance abdominal cavity. Then what is the set flow? The set flow is for Veris needle is 2 to 3 liters per minute, and for if you giving trocar, the set flow is for Veris needle is 2 to 3 liter, because you can see Veris needle is very thin, so you have to give 2 to 3 liter per minute. For trocar you have to give more, that is 10 to 14 liters per minute. Okay, then actual pressure, but this is the set pressure. Then what is the actual pressures? What is actual pressures? Actual pressure is the must not exceed the set pressure. The actual pressure, it must not be exceed your set pressures. Okay, so usually the value is less than 10 mmHg, that the start confirm the proper insertion of variation delta. If the actual pressure is less than 10 mmHg, that will confirm your proper placement of Veris needle. Okay, so value of high pressure, that is near 25 is indicate large resistance to flow. If it is so 25 mm actual pressure, that means the needle has stock inside the abdominal wall. The needle has been stocked inside the abdominal wall. That will indicate the large resistance. That will indicate large resistance to flow of your gas into the cavity. It will the flow has been gone inside the layer of the abdominal wall. That will cause indicates it. What it indicates? If the initially just after the insertion, if the pressure is very high, that is near 25 mmHg, that itself indicate the large resistance to the flow of gas. That itself indicate improper insertions of your Veris needle. Very important statement. So actual flow and total volume of gas used. Normal BMI patients, if you how much volume of gas used, normal BMI, the pressure is 2 to 2.5 liter gas has to be used. If it is a thin patients, it is use only 1.5 liter. Obese patients, it will use 3 liters. Okay, what are the complications? Already you know that injury to the omentum, bowel vessels, bladder injury to omentum, and injury to grid. Management of complication: don't remove needles, explode the abdomen. If it is if you directly what are the management of your complications? So what are the complications during the Veris needle insertions or your trocar entry? First is your injury to your vessels. What are the vessels? Aorta, inferior epigastric artery, because inferior epigastric is in the lateral boundary of the your Hasselback triangles. So it can injure your over distended stomach or bowel. Splenic injury, if splenomegaly is there while entering into your palmar point. Pneumothorax, if you enter palmar point 9th intercostal space. Bladder injury, suprapubic port has a chances of bladder injury. Injury to ilioinguinal, iliohypogastric knob, because when you are giving a lateral floor placement 2 cm above anterior superior iliac spine, at any point just medial to your anterior superior iliac spine. What is the lateral port has to be given 2 centimeters above? This is the anterior superior iliac spine, 2 centimeter above, 2 centimeter just medial, 2 centimeter above, 2 centimeter. This is the lateral for 2 centimeter above, 2 centimeter medial. Okay, so basically during the lateral port entry, ilioinguinal and iliohypogastric, compression of the vena cava interferes with the diaphragm movement. If you giving excessive insufflation stress, so that will cause compressive effect on your vena cava and decrease the diaphragm movement. So vessel injury, aorta, inferior epigastric artery, these are the injury that can be happens. Okay, injury to the vessels, injury to the bowel, stomach, splenic injury, everything can be happens. Okay, then pneumothorax, bladder injury, suprapubic, ilioinguinal, iliohypogastric knob injury, vena cava injury, influence the diaphragm movement, excessive into circulation pressures. How will manage the complications? How will manage the complications? If you enter, don't remove the needles first. Don't remove needle. Okay, explore the abdomen. Then immediately you have to explore it. Then call the concern on the facility. Okay. The secondary flow placement on the direct vision has to go here as with 3 to 5 mm, occasion 15 mm port depending on the size of the instrument. Lateral trocar, lateral to inferior epigastric artery, the 5 cm superior, 8 cm lateral to pubic symphysis. Okay. Suprapubic trocars, the lateral trocar, 2 finger breadth above the pubic symphysis, above avoid bladder injury, 2 cm breadth above the pubic symphysis. In laparoscopy image, you can see this is your medial inferior epigastric artery. This is the inferior epigastric artery. This is the insertion of the round ligament. You can see the uterus. From the uterus, the round ligament is going inside the inguinal canals, that is the superficial deep inguinal rings, the medial umbilical ligaments. Thank you. If you like these lectures, please subscribe. I'll discuss some actual pressure on set pressures already. The set pressure should not be usually to 10 to 14 mm is the pressure, maximum pressure the machine will allow to insert the abdominal cavity, that is 14 to 16 mm, maximum not allow, maximum is 18 to 20, not should not be more than 25, it will cause compressions. And the set flow is 2 to 3 liter, if you very needle 10 to 40 liters for trocars, everything. And the actual pressure should not be exceed the true set pressures. Okay, actual pressure if you exceed more than 20, that will cause compression effect. Must not be exceed the set pressure. If less than 10, that means confirms on the very needle. If it is 25, that should not think about. There will be some resistance to the flow of gas, indicate improper insertion of the very needle. Thank you. If you like this lecture, please subscribe. Thank you.